Welcome to the patient-centered medical home and patient-centered medical home neighborhood annual education. Upon completion of this course, the learner will understand the state of healthcare payment structures, understand the definition and history of PCMH and PCMH N, understand and demonstrate knowledge of key concepts, components, and transformation under the PCMH and PCMH N care model, understand how PCMH and PCMH N is fused into daily activities, and understand who to contact for additional information. PCMH is a care delivery model in which patient treatment is coordinated through primary care physicians to ensure patients receive the necessary care when and where they need it in a manner they can understand. PCMH-N is a care delivery model that enables specialists and subspecialists to collaborate and coordinate with primary care physicians to create highly functioning systems of care. The world of healthcare is changing. Healthcare will be based on value, not volume. Healthcare will no longer be about how many patients can be seen or how many tests and procedures can be ordered. Instead, it will be about patient outcomes and cost. This means collaborative coordination is necessary between PCPs, specialists, and facilities. Value-based care is reimbursement that ties payments for care delivery to the quality of care provided by providing care that is safe, appropriate, and cost-effective, meaning the right care at the right time in the right setting. According to the U.S. Department of Health and Human Services under the Agency for Healthcare Research and Quality, Ed Wagner's chronic care model contains 6 elements focused on driving quality improvement ideas around chronic disease management. These elements are healthcare organization and leadership, coordinated delivery system design, clinical decision support, clinical information systems, linkage to community resource, and support of patient self-management. By implementing and coordinating the ideas, we will have developed a prepared, proactive practice team and an engaged patient. This model can and will improve patient outcomes for chronic disease management. Patient-centered medical home is an approach to provide comprehensive primary care for all patients. PCMH is a healthcare setting that facilitates partnerships between individual patients, their personal physicians, and when appropriate, the patient's family. In 2007, the 7 joint principles were introduced. They are the following. Whole person orientation. The personal physician is responsible for addressing all aspects of the patient's healthcare, including their physical, mental, spiritual, and emotional health. This also includes care for all stages of life and end of life. Care is coordinated and integrated across all elements of the healthcare system and local community to ensure patients are receiving the care where and when they need it. Safety and quality. Practices work with their patients to achieve the highest patient-centered outcomes by using evidence-based medicine to guide decision-making. The personal physician. Each patient has an ongoing relationship with their personal physician. Enhanced access. Making care available 24/7 through methods such as open scheduling, extended hours, urgent care partnerships, and on-call physicians or answering services. In the physician-directed practice team, the physician leads a team of individuals who take responsibility for the care of the patients at the office. And lastly, patient-centered medical home designation is a part of many incentive or uplift payment options which would compensate for many insurance companies not raising their fee schedules in a number of years.
Blue Cross Blue Shield of Michigan has observed that PCMH designated doctors are exceeding in managing their patients' care to keep them healthy and prevent complications that require treatment with expensive medical services. Year over year, Blue Cross Blue Shield of Michigan performs comparisons, and as you can see, the designated offices outperform the non-designated offices.
To increase practice engagement, the office and MPP will be in constant communication to achieve PCMH designation. Here are the key components needed. Provider champion, PCMH Pcmh N champion, collaboration between office staff and MPP, regularly scheduled meetings, and a toolkit evidence binder. The success of your PCMH designation depends on this engagement and excellent communication on all sides. Some helpful ideas to transform your practice into a patient-centered medical home are as follows. Plan, do, study, act cycles, or PDSAs, team huddles, keep an open mind, try new ways of doing things, learn from the feedback you receive, stay positive, and offer your ideas. The plan, do, study, act cycle is something that we do all the time without realizing we're doing it. Often, a PDSA is triggered when the office notices a problem and wants to fix it. For example, one office that we worked with noticed that they were not getting retinal eye exam reports for their diabetic patients and decided to complete a PDSA cycle. Plan. The office discussed the problem and decided they would talk to local eye specialists. Do. The referral coordinator at the office then called each local eye specialist and explained that the office would like to receive copies of the retinal eye exams for their diabetic patients. Study. It was discovered that many eye specialists did not know that the primary care physicians received a score for completed retinal eye exams, and we're happy to send documentation to the primary care physician. Act. The office developed a diabetic retinal exam fact sheet and distributed it to all the local eye specialists. The result of the PDSA cycle was, over time, the primary care site was able to move from 15% to 55% completed retinal eye exams.
PCMH and Pcmh N life cycle. First, the physician must participate in a physician group incentive program, also known as PGIP. The physician organization will nominate each practice to Blue Cross Blue Shield. Blue Cross Blue Shield will then designate the primary care physicians on a 2-year basis and recognize the specialists based on their performance throughout that time frame. Any new practices will be evaluated for a mid-year nomination, and these results will determine their value-based reimbursement.
These are the domains of the Blue Cross Blue Shield PCMH and Pcmh N program. Under each domain, there is criteria that result in 150 possible capability points. The requirement for a PCMH designation is a minimum of 44 capability points. The Mpp quality team and PCMH champion will work from a toolkit that over time evolves into an evidence binder for each domain with supporting evidence to meet each point. The binder also ensures that evidence is in place should the office be selected for a validation site visit from Blue Cross Blue Shield. The Mpp quality team will assess and submit your capability points each year. Additionally, there are 6 domains that require a written policy that must be reviewed and signed off by the staff on an annual basis. These domains are patient-provider partnership, individual care management, test tracking, linkage to community resources, coordination of care, and specialist referral process.
Primary care providers must have the following core capabilities fully in place in order to be designated. In addition to the core capabilities, Blue Cross Blue Shield may add or remove capabilities on a yearly basis.
Domain 1 is the patient-provider partnership, which includes staff education, communication tools such as the PCMH brochure, flyers, signage, and conversations between patients, trained clinical staff, and providers. It also includes the patient-provider agreement, which defines provider and patient responsibilities. These completed agreements are reported and tracked quarterly. Outreach to patients who have not completed an agreement is also being done within the office. Domain 2 is the patient registry. The utilization of a patient or population registry system allows offices, providers, and POs to access a specific patient population. For example, if we wanted to see the status of a diabetic population, the registry will pull that information together in one report. That report can then be dissected into great detail to access opportunities or gaps needed, such as eye exams, hemoglobin A1C levels, or statin medications. The registry also provides a point-of-care summary for each patient at their visit. The summary will include the same opportunities or gaps needed based on evidence-based guidelines for optimal patient care. Often, EMR or EHR systems can interface with registries, easing manual data entry burdens. Domain 3 is performance reporting. The patient registry allows us to generate reports to display performance over time and filter to all patients or a specific group of patients. Performance reporting helps the office to evaluate progress over time, catch upward and downward trends, and assist with outreach to patients for closing gaps.
Domain 4 is individual care management. As your office implements processes and strategies for the entire patient population, this section will build with your growth in the PCMH model. The use of flow sheets, EMR, or registry may assist offices in identifying opportunities and ensuring evidence-based care. A planned visit is a written plan that identifies the roles and responsibilities of each member of the office team to ensure that needed care is provided in a consistent manner. Provider-delivered care management, or PDCM, is a way for the practice to engage patients outside of their regularly scheduled appointments utilizing care managers in the practice. Patient satisfaction survey results will be shared with staff on a quarterly basis. Some ways to meet this criteria are posting the results in the employee areas or discussing during a staff meeting. Self-management goal setting and disease action plans will help the patient become part of the decision-making process in their care. Scheduling reminders and appointment tracking provide safety nets to ensure that all the loops in the patient care are closed each and every time.
Domain 5 is extended access. Extended access improves patients' access to healthcare by ensuring that the patient has 24/7 access to a clinical decision maker via phone after hours. It also involves developing a partnership with local urgent care clinics. The urgent care partnership improves communication by outlining the responsibilities shared by the primary care provider and the urgent care provider. The urgent care provider agrees in writing to send a summary of the patient's visit to the primary care provider within 24 hours of the visit. In return, the primary care provider refers patients to the partnered urgent care. Letting patients know about your urgent care partner or partners is perhaps the most important activity in Domain 5. Offices inform their patients of their partnered urgent care clinics through their patient brochures, flyers, handouts, the after-hours message, or face-to-face discussions with the primary care team. Some offices have also developed decision support brochures that educate patients regarding when to seek an appointment with the PCP, when to visit the urgent care clinic, or when to go straight to the emergency room. Lastly, a list of interpreter resources is required to be maintained at the office so that a translator can be found should a patient need one. Domain 6 is test tracking. Within this domain, the practice has a policy in place requiring tracking and follow-up for all tests with identified timeframes for notifying patients of the results. It includes a process for patients to obtain the results regardless if they are normal or abnormal, along with the recommendations for follow-up care with defined timeframes. All steps included in this process should be documented in the patient's record.
Domain 8 is electronic prescribing. The use of electronic prescribing includes the ability to send prescriptions electronically, show medication formularies, show contraindications between medications, and identify possible allergic reactions. The electronic prescribing of controlled substances is an option should the office choose. When prescribing controlled substances, the practice should initiate a controlled substance agreement per local law. This agreement should be shared with the patient's entire healthcare team.
Domain 9 is preventative services. This domain focuses on identifying, educating, and counseling patients on preventative services such as mammograms, colorectal cancer screenings, and annual well visits. Also, personal behaviors such as tobacco use, use of sunscreen, and lead exposures. Patient outreach can be conducted in the form of electronic, phone, or written communication for the patients in need of these services. Standing orders are a set of written approved guidelines for trained staff to follow when completing designated tests, orders, and processes without action from the provider first. These orders are to be reviewed and signed off by the providers annually. Asking the patient at every visit if they have obtained outside interaction with any other healthcare entities is a crucial role in the PCP and specialist offices. For example, a patient has their PAP done at an OBGYN office, or a flu shot is given at a local drugstore. The office is responsible for obtaining written documentation of this event for the patient record. Education and training for the staff ensures that they are kept up to date with the latest news on preventative services, health behaviors, and information on diseases. Domain 10 is linkage to community resources. The purpose of this domain is to connect patients with some of the many resources available to them in the community. Linking your patients to resources for food, shelter, transportation, education, or child care, for example, can make a tremendous positive impact on their health and well-being. MPP maintains community resource guides for each county that we serve. These guides are updated twice a year and are free to anyone who would like to use them. For full credit in Domain 10, your office will develop and implement a community referral policy. This policy outlines how you identify patients for community referrals and how that referral is conducted and tracked. Your community referral policy should also include a protocol for documenting, tracking, and following up on any high-risk or emergency community referrals within 24 hours. These are cases where we want to ensure the patient received the services they need. For example, a patient that uses medical equipment such as oxygen is at risk of their electricity Domain 11 is self-management. Self-management is a key way to address behavior changes with patients. It also brings about greater awareness of the patient's active role in managing their own health and well-being day to day. When your office decides to implement self-management with patients, you may use motivational conversations with the patients, goal-setting worksheets, patient workshops, follow-up phone calls, or some combinations of these approaches. It is required that an ongoing self-management process is actively in place and used with your patients. It is also required that one of MPP's team members who has been trained by the Self-Management Resource Center completes a refresher course with your staff annually.
Domain 12 is the patient portal. The patient portal is a secure two-way option for electronic communication between the patient and the physician office and is available for all patients. The patient portal may also have the ability to include reviewing test results and approving chart records, requesting and making appointments, requesting medication refills and renewals, requesting an e-visit or televisit, the ability to send and receive education materials, community resources, and self-management information.
Domain 13 is care coordination. Coordination of care involves the PCP having an active relationship and contacts throughout the community for patient care. Some of these relationships include urgent care and emergency department, specialists, PT/OT, visiting nurses, and group homes. Care coordination fosters these relationships by monitoring patient population for admissions, discharges, and transfers. Practice has a process in place for exchanging necessary medical records. Practice has a systematic approach to track care coordination activities for each patient with a chronic illness. And practice has a systematic approach to flag a potentially time-sensitive health issue for all patients with a chronic illness. Domain 14, Specialist Referral Process. Referral tracking is very similar to test tracking. Through referral tracking, your office can identify at any given time the referrals that have been made and any referrals that are waiting for a consult or report back. A referral starts with your office, with providing the patient with detailed information about the specialist they are going to see. The patient should understand why they are going to a specialist, how soon they should complete the referral appointment, and the importance of returning specialist documentation to the primary care office, and how the specialist appointment scheduling will be handled. Tracking referrals ensures that patients have every chance to complete the referral. Sometimes a patient may lose the referral information and never schedule themselves for an important screening or therapy. In these cases, your follow-up may make the difference in that patient getting the care that they need. We implement tracking in PCMH offices because it is the only way to be sure patients aren't slipping through the cracks. For full credit in Domain 14, practices are required to have a policy in place describing in detail how each and every referral is tracked and how your staff follows up on any missing referral information. All follow-up actions taken by staff are documented in the medical record. The PCP Specialist Agreement is a roadmap to opening communication and aligning roles and responsibilities between providers. Also, this is a requirement for specialist VBR annual nomination. Some of the expectations listed are: specialist and primary care providers are expected to be in communication about their patients and to provide timely written and/or verbal reports on consultations within 10 business days. Also, care should always be directed back to the PCP as soon as it is appropriate to do so, and the specialist will reinforce the principles of the Pcmh N model. MPP has developed a quality metrics quick reference guide. It is updated yearly with the top 10 focus measures, along with helpful tips and documents to improve quality scores. If you have not yet received copies of the reference guide and are interested, please contact your MPP quality team member for a copy. Utilization performance includes monitoring ED visits and high and low tech radiology testing. The learner will now be able to demonstrate knowledge of healthcare payment structures, define PCMH and PCMH N and its history, demonstrate knowledge of key concepts, components, and transformation under the PCMH Pcmh N care model. Demonstrate knowledge of the PCMH and Pcmh N program within their daily activities.